For question 15, the correct answer is B, low ceruloplasmin, as he has Wilson's disease, evidenced by the Kaiser-Fleischer ring. For question 16, the next best step is right upper quadrant ultrasound to assess her liver and hepatobiliary tree. She most likely has alcoholic cirrhosis, which can be seen on ultrasound as fibrotic and nodular changes to the liver parenchyma. In cirrhosis, chronic hepatocellular injury leads to fibrosis and nodular regeneration of the liver, ultimately impairing its many synthetic and metabolic functions. The impairment of these functions is what causes the symptoms and complications from cirrhosis. The inability to excrete bile leads to hyperbilirubinemia, leading to itching and jaundice. The inability to metabolize estrogen and increased conversion of testosterone to estrogen leads to gynecomastia, palmar erythema, spider angiomas. The inability to clear toxins and ammonia leads to hepatic encephalopathy. Decreased synthesis of factors 2, 7, 9, and 10 lead to increases in the INR and risk for bleeding. Decreased synthesis of albumin leads to edema. Portal hypertension leads to splenic sequestration, causing thrombocytopenia, as well as ascites, which can increase the risk for spontaneous bacterial peritonitis, as well as esophageal and other GI varices. The inflammation of the liver over time increases the risk for hepatocellular carcinoma. Cirrhosis can be diagnosed clinically based on exam findings, lab evidence of synthetic dysfunction, and radiographic evidence of a nodular fibrosed liver. Biopsy is the definitive test for diagnosis, but it may not be necessary unless the cause of the cirrhosis is unclear. Once cirrhosis has been diagnosed, the severity should be determined using the MELD score and Child-Pugh class, and patients should be assessed for any signs of decompensation, and they should be screened for complications. Cirrhosis has many possible causes, most of which we've already covered. Alcohol and MASLD are the two most common causes of cirrhosis in the U.S., followed by hepatitis B and C. Other systemic causes we have not covered yet that can cause cirrhosis include long-standing cardiomyopathy causing venous congestion, or infiltrative causes like amyloidosis or sarcoid. When no definitive cause of cirrhosis is found, we call this cryptogenic cirrhosis. Patients with a new diagnosis of cirrhosis should be screened for viral hepatitis, have iron studies done, undergo workup for autoimmune or inherited causes of cirrhosis, and have an extensive review of their family history, substance use history, and medications. If no cause can be identified based on history and non-invasive testing, biopsy can be considered. People with compensated cirrhosis may have few to no symptoms. People with decompensated cirrhosis may have many manifestations. These can include GI manifestations like anorexia, nausea, and vomiting. They may develop kidney failure from hepatorenal syndrome. They will likely have jaundice, spider angiomas, and palmar erythema, gynecomastia, and amenorrhea in menstruating patients. Cardiovascular complications like cardiomyopathy and peripheral edema, neurologic complications like hepatic encephalopathy and asterixis, hematologic complications like thrombocytopenia, anemia, coagulation disorders, and splenomegaly, and effects of portal hypertension like esophageal varices, gastric varices, ascites, caput medusa, and anorectal varices. Patients will also typically have hyperbilirubinemia and hyponatremia. Patients may have all or just some of these manifestations, depending on the severity of their disease. Ascites is the most common complication from decompensated cirrhosis. This is accumulation of fluid in the abdominal cavity. This can be managed with diuresis using furosemide or spironolactone. Dietary sodium restriction to less than 2 grams per day may also be helpful. Fluid restriction is indicated only if the serum sodium is less than 125 milliequivalents per liter. For refractory ascites, patients may need frequent large volume paracenteses, during which you may need to give albumin to prevent renal failure when taking out a large volume. Patients presenting with ascites for the first time should undergo paracentesis for fluid cell count, protein, albumin, and culture. The SAG should be calculated, as this value can help distinguish the possible causes of ascites. In patients with ascites, spontaneous bacterial peritonitis is a common complication. People should be screened for SBP the first time they have ascites, if they have ascites and they present with fever or signs of sepsis, or if they are presenting with acute hepatic encephalopathy. SBP is diagnosed when there are more than 250 neutrophils seen on the cell count done on the acidic fluid from paracentesis. The gram-negative culture does not need to be positive to diagnose SBP, and frequently isn't. We should not wait for culture results to begin treatment for SBP. Empiric first-line therapy should include an IV third-generation cephalosporin, like ceftriaxone or ceftazidime, and then you can de-escalate or switch to PO depending on your culture results and if the patient's clinically improving or not. IV albumin is also typically given, usually on days 1 and 3. Some patients may need prophylaxis with antibiotics to prevent future episodes of SBP. Primary prophylaxis should be given to people with cirrhosis when they have a GI bleed, typically with ceftriaxone for 3 days. Patients with cirrhosis should also receive prophylaxis for SBP if they have ascites with a protein of less than 1.5 grams per deciliter or a SAG ratio of less than 1.1 grams per deciliter. Secondary prophylaxis or prevention of SBP in someone who has already had at least one episode of SBP should be given to anybody who has ever had an episode of SBP. Prophylaxis is typically done with a fluoroquinolone, trimethoprim sulfamethoxazole, or an oral third-generation cephalosporin. Hepatic encephalopathy is another common complication of decompensated cirrhosis. This is made by a clinical diagnosis. There is no cutoff of the ammonia level that is diagnostic for hepatic encephalopathy, but checking it if you suspect it can be helpful to compare it to a patient's baseline. It often has a precipitating factor, like an infection, GI bleed, dehydration, or medication non-adherence. It should be suspected when patients with cirrhosis present with acute delirium. On exam, patients may exhibit asterixis or a flapping tremor when they hold their arms out. It is typically treated by treating the underlying cause, in addition to lactulose to acidify the colon to decrease gut nitrogen production, as well as rifaximin, which is an antibiotic that is not absorbed systemically and can help reduce the burden of nitrogen-producing bacteria in the gut. Treatment with lactulose and rifaximin can also help prevent hepatic encephalopathy. Lactulose dosage should be titrated up until patients are having 3 to 4 bowel movements per day, which can make adherence difficult. If a patient undergoes transjugular intrahepatic portosystemic shunt, or TIPS procedure, to help reduce refractory ascites by decreasing portal hypertension, this can increase the risk for hepatic encephalopathy, as it diverts blood from the portal vein to bypass the liver, preventing ammonia from being filtered by whatever functional hepatocytes may remain. To sum up, the mnemonic VIBES can be used to remember the components of the management of decompensated cirrhosis. V is for volume. Patients may need restriction of salt and fluid or diuretics to maintain euvolemia, and patients with ascites may need frequent large volume paracentesis. I is for infection. We covered this in our section on SBP in the previous slide. B is for bleeding. Patients should be screened for esophageal varices and receive either primary or secondary prevention with non-selective beta blockers or banding if found on endoscopy. E is for encephalopathy, as we just previously discussed. And S is for screening and surgery. Patients should undergo age-appropriate cancer screenings as well as screening for hepatocellular carcinoma every 6 months with a liver ultrasound. Suspicious lesions should be assessed with a triple-phase CT scan. Patients should make sure their vaccines are up to date and be counseled to avoid alcohol and other hepatotoxins. Patients with a MELD higher than 15 or who have decompensated cirrhosis, regardless of MELD, should be referred for possible liver transplantation. Let's wrap up with a question.